Thank you for coming to the first podcast for neurologist.com. I am Dr. David Sutterth. On this channel, we will be discussing many different types of brain disorders, brain aging, brain health, and longevity, but we will mostly focus on concussion, also known as mild traumatic brain injury. Unlike the name might suggest, this type of brain trauma is anything but mild, at least for the injured person. Although concussion does not involve craniotomies, wheelchairs, 24-hour nursing care, it is a serious disorder of the brain. It is also very common, affecting several million people each year in the U.S. Most of them are missed by the injured person as well as the healthcare apparatus, so we don't have a precise count. There are many reasons these injuries defy detection, and we'll make an attempt to explore why that is and examine the many controversies surrounding this disorder. Through podcasts and interviews with researchers and clinicians, hopefully a clearer view of this potentially devastating condition will emerge and provide implications of a practical nature. What can we do about this? Actually, a lot. Strangely, a diagnosis can be profoundly therapeutic, as we will see below. Once again, thank you for joining us today. Please remember, this podcast channel is here only to provide general information and not to diagnose or treat individuals. On this website, concussion and mild traumatic brain injury will be used interchangeably. The manifestations of this type of brain disorder are quite diverse and can essentially affect any part of the body. Brains are also frequently damaged simultaneously with necks, backs, shoulders, abdomens, all of which can make it harder for us to make a diagnosis. Hemorrhage, broken bones, and other injuries will often divert our attention from the actual brain injury. The TBI symptoms an individual notices may be related to memory or concentration. The patient may be unusually irritable, often with other suggestions of personality change. She may be dizzy. Visual complaints are common, particularly close up, like, for example, working on a computer. And to illustrate this disorder, I think it would be a good start with an example, and we're going to begin with a patient I saw a few weeks ago in my clinic. We call this a case history, and is an extremely potent didactic tool in medicine. This particular case is very instructive and unfortunately very typical. So we will begin with this woman's story in her own words, and in passing describe the clinical process that a neurologist will pursue in the investigation. We always start with a history in neurology, which is probably the most important part of the encounter. When did the problem start? How severe are the symptoms? Does it interfere with life functions or inhibit the lifestyle of the individual? These are big issues that ultimately govern the diagnostic process. The physical examination follows in a more formal sense thereafter and is largely guided by the history. This is the hands-on part, not available by Zoom, and probably the most important part of the examination, more so than in other specialties. A mental status examination will not be the primary focus of attention in a patient with sciatica, but becomes crucial when we're talking about a TBI. Actually, the history starts more informally with the handshake and introduction. As Dizzy Dean wisely noted, you can observe a lot by watching. In our example, we noted ample evidence of great emotional stress. The final link in the diagnostic process is the review of blood tests and imaging studies, as well as ER notes and records. In our case below, MRIs were reviewed with the patient. So we'll start with this patient. Her name for our purposes will be Elisa Green. She is a 36-year-old woman who was in a traffic accident approximately 1 year prior. She was referred to this office not because of the accident or even any suspicion that her symptoms might be related to the event. It was the headaches. The patient had a long history of migraine and typically had 1 to 2 migraines per year. The attacks were usually one-sided and associated with increased sensitivity to light and sound, as well as severe nausea to the point of vomiting. The headaches tended to not be terribly disruptive, and responded very well to anti-inflammatory medications. Over the last year, the patient developed a severe aggravation of her symptoms and also a new type of headache. The actual migraines were occurring on a much more frequent basis, typically occurring 1 to 2 times per week. They had not been responsive to her usual measures and were noted to be more severe, disabling to the point that she was concerned about keeping her job. Because of her neck and back pain, Elisa had started seeing a chiropractor who helped significantly with this spinal discomfort. She was treated for many months but gave up ultimately on the treatments when her pain stabilized. By the time this injured individual made it to my office, she still had bothersome and lifestyle-disturbing neck and low back pain, which had improved slightly but continued to be a factor in her life. The patient also reported that she had some mood disturbances over the last year. She described feelings of depression, sadness, lack of motivation, anhedonia, or lack of the ability to experience pleasure, and she had become extremely impulsive in speech and was prone to make remarks that were perceived by others as being brutal or insensitive. Obtaining third-party input is essential in diagnosing and treating TBIs, which can obviously affect the awareness of the injured person's behavior and performance. The history is not complete until the spouse or other adult has been consulted. In this example, the husband had noted that the patient had become very abrupt and insensitive in her behavior, and Mrs. Green herself was very reluctant to admit that her treatment of her children was not at its very best. Aside from the headaches, the patient continued to experience rather severe neck and low back pain, which interfered with many activities, including exercise. Lisa also presented a number of cognitive complaints. She noted that she had difficulty paying attention, multitasking, etc. She also knew that she frequently made errors that she was unable to detect herself, despite second-guessing herself on a frequent basis. Her errors did not escape the attention of her supervisor. Lisa also complained of mental fog and fatigue. Tasks took longer to complete, and she was often in need of help with routine matters in the office. And her eyes were not cooperating, particularly at close quarters. An optometrist provided no help with these distressing symptoms, and she was unable to explain why she needed sunglasses indoors. She didn't bother to see an ear, nose, and throat specialist for the ringing in her ears, which was probably imaginary too. During the attacks of migraines, she was lightheaded and was very sensitive to light, and that even in the absence of migraine, light and noise could be intolerable. Lisa had no significant history of depression or anxiety in the past, but stated that since the accident she'd been very frightened of driving and had become super high-strung to the point that she was easily startled at home or work. The jumpiness was nearly fatal behind the wheel. She describes herself as formerly being quite social. Since the event, she had become something of a recluse and only left the house when absolutely necessary. She experienced frequent flashbacks of the event and described repetitive nightmares of an accident theme. Overall, the patient felt that her general health had deteriorated. She stated that she felt cold all the time, and she had gained approximately 15 pounds and noted a craving for carbohydrates. Elisa could not exercise and did not feel rested when she arose in the mornings. The husband had described quite prominent snoring and even some brief periods of apnea, which terminated with a loud snort. She never did that before. Resignedly, Elisa lamented that she felt there was little to look forward to in life and that she was even beginning to doubt her own sanity. At no time had she been able to relate her symptoms to the automobile accident, aside from the neck and low back pain, of course. The patient's past medical history was negative for any chronic medical problems. She had surgery on the left shoulder. There was no previous history of neck or back pain or injury. She was taking no medications. Elisa worked as a receptionist in a local physician's office. The family history was positive for migraine, but negative for mental illness. On further questioning, the patient did admit to some ringing in the ears, but otherwise the review of symptoms was negative. On examination, the blood pressure was elevated, She was overweight, and there was evidence of inflammation of the nerves at the back of the head on both sides. There was also a change in the patient's reflexes. The overall mood appeared to be depressed, and she was noted to wring her hands during the examination. The speech was pressured, and she frequently interrupted herself. She otherwise performed fairly well on mental status examination and was able to remember 3 objects at 5 minutes and 6 presidents in the proper order. No speech or language disturbance was noted. Incidentally, the thyroid appeared slightly enlarged. After the examination, the patient was informed that she appeared to be somewhat depressed, had chronic post-traumatic stress disorder, and a very clear history of concussion. Does that sound good to you? It did to Elisa. Getting a diagnosis that explained in a very sensible manner was a source of great liberation for this unfortunate woman. These diagnoses were able to weave all the symptoms together in a rational manner that ultimately exonerated her in her own mind from being a hopeless hypochondriac. A rather profound emotional response ensued. Ms. Green began crying, not only from being sad about the situation, but rather for relief that there was a clear reason for her symptoms, i.e. the head injury. The patient was informed that these were very typical symptoms, and her prognosis was, for the most part, very good. So we'll have more to say about this patient and discuss Elisa as her case unfolds. But this patient illustrates in a very clear and typical manner many but not all of the clinical features of concussion. This case also demonstrates that the medical profession could respond better to head injury. One of the great tragedies we see with traumatic brain injuries is they are frequently not diagnosed, and if they are diagnosed, the long-term symptoms are often not considered to be related to incident by the patient or even the caregivers. This case is a perfect example of this. Another feature of traumatic brain injury that merits some consideration is the broad spectrum of symptoms that essentially affect every part of the body. I'm not aware of any other medical syndrome with such pervasive features. We have symptoms related to the head and brain, the mood, neck pain, low back pain, mobility and balance, energy regulation, hormonal control, and so on. And we see here that there are often general health issues that intersect with this type of injury. Here I'm thinking of the patient's elevated blood pressure and the suspected thyroid problem. The swelling of the legs, fatigue, slow reflexes, and cold intolerance are fairly typical for thyroid that is not functioning properly. It is very possible that these were pre-existing, but the patient did not have the symptoms prior to the injury. Traumatic brain injuries often involve the endocrine system, and this has been known for over 100 years, but only rarely are the appropriate tests considered. The master endocrine center, the pituitary gland, is at the base of the brain and can easily be injured in this type of event. The pituitary is very delicate and has a quite complex and vulnerable circulatory system. So while it's not known if the accident has caused the symptoms, it certainly merits consideration. In my clinic, if I have the slightest indication that there might be a pituitary disturbance in a patient, I will order a rather involved endocrine panel, a blood test. A related issue is the patient's blood pressure could easily be related to the stress and hyperactivity of the autonomic nervous system, which is involved in post-traumatic stress disorder. And we will discuss later these issues and hopefully have an interview with an authority on this subject. Ms. Green related that she had some sensory problems, and here we will include the migraine. It is common for people who have migraine to develop new headaches and experience some intensification of their previous migraine syndrome post-concussion. The headaches often change in frequency, severity, duration, and can change to some degree in terms of the associated symptoms such as nausea, vomiting, light sensitivity, etc. The response to medication also may change. In this case, we have the addition of a new type of headache, which I believe is occipital neuralgia, and appears to be on both sides, which is very common after concussion, especially if there is involvement of the neck. The treatment for this type of headache is very different than the treatments we can offer sufferers of migraine. Patients may also be very sensitive to light, even when headache-free. Elisa also described being dizzy and reported that she had difficulty looking at a computer screen for prolonged periods of time. The visual symptom is very often affected with concussion in many different ways, especially with regard to adaptations that require normal muscle control. These abnormalities can be demonstrated with sophisticated imaging software that can record eye movement aberrations. iBox is now in clinical use and is a good example of this innovative technology. The patient's balance problem is often referred to as persistent postural perceptual dizziness, PPPD, and will require lengthy vestibular rehabilitation. Elisa described furthermore that she had difficulty paying attention and experienced memory problems. Now, memory problems can be related to many factors besides actual involvement of the memory circuits. Attention problems frequently masquerade as a memory problem. If we're not able to focus our attention and really listen to what we're trying to grasp, then there will be no record of what we were trying to remember. This patient appears to have both of these disturbances. She compensated by writing down information for later use. She was disorganized and she had difficulty with self-monitoring, including impulsivity. These are all examples of frontal lobe symptoms, more specifically described as the executive system. The executive system is the higher functioning of the human brain, and typically these functions are involved in head injuries. Now let's go back to the emotional side of this story. This patient really should have seen a psychologist, neurologist, or psychiatrist earlier in the course. It is believed that some cognitive behavioral therapy and other forms of treatment can be helpful in terms of preventing chronicity with regard to post-traumatic stress disorder. This patient could benefit from many types of treatment, including medication, counseling of various types. But remember, early treatment is essential. All these were things that I plan to do with this patient. She may be a good candidate for transcranial magnetic stimulation, also known as TMS. Much more on this exciting treatment later. So let's sum up the management of this patient. I've recommended that the patient have an MRI scan, including conventional study, diffusion-weighted images, and diffuse tensor imaging, DTI. We'll have much to say about advanced diagnostics later, which are needed in TBI, because X-rays, CAT scans, and even conventional MRI scans are often normal in concussion. These more advanced techniques that can examine at a microscopic level can demonstrate the changes in the white matter, which is the usual culprit in this type of injury. So besides the MRI scans, I've recommended the patient have an endocrine panel, which I described earlier, and she was referred to a psychologist. A cognitive screening was recommended. The patient will certainly need more testing, including consultations with ENT and an ophthalmologist. For example, she may also need more in-depth neuropsychological testing and other measures that we will discuss at length. Hopefully, we will have some interviews related to these subjects posted soon. So what is Elisa's prognosis? She may not recover completely, although she should clearly improve, even dramatically. Elisa has dysfunction in her higher cortical functions and severe emotional trauma. So focusing on these issues will be crucial for the patient. We hope this brief presentation was helpful. The emphasis today was to provide a simple preview of an enormously complex and controversial topic. More in-depth discussion surrounding the topic of brain injury will be coming in the near future. Thank you for your attention, and check for future podcasts and interviews at neurologist.com.